I have no disclosures related to this topic. CORAL stands for Cardiovascular Outcomes in Renal Atherosclerotic Lesions. This study was in 10 years in the design, execution, and analysis. It was sponsored by the NIH and was to determine whether the rapid expansion in renal stent procedures was justified on clinical, economic, and scientific grounds. So 2 years ago at this meeting, I discussed the results of the Hercules trial, of which we were a participating site. This was a registry study looking at the outcomes for patients with renal artery atherosclerotic stenosis and hypertension. The Hercules study is similar to other registries and case series for treating renal artery stenosis. These patients all had ultrasound-confirmed stenosis prior to enrollment. The study showed that there was a sustained decrease in hypertension following stent deployment, with the blood pressure shown here pre, post, 1 month, 6 months, and 9 months after stent deployment. The higher the entry blood pressure, the greater the subsequent decrease in pressure. And for patients who came in with a blood pressure over 180 millimeters mercury, there was almost a 50 millimeter drop in blood pressure associated with deployment. Not shown for the Hercules study is that there was no biochemical marker such as BNP at baseline that predicted outcomes. My take on this study was that it confirmed the clinical impression that renal artery stenosis can cause hypertension and the problems associated with it, and that this was fixed by opening up the blockage. The CORAL study was an open-label, randomized comparison of contemporary medical therapy for all patients, which included an ARB, a vasodilator, volume control with a diuretic, a potent statin, antiplatelet therapy, and diabetes control. Everyone had that. Half of them were then randomized to renal stenting. The primary endpoint was cardiovascular or renal death, myocardial infarction, stroke, hospitalization for heart failure, progressive renal insufficiency or renal replacement, in other words, dialysis. At entry into the study, the mean systolic pressure was 150, the GFR was 58, and the core lab angiographic stenosis was 67%. Half the patients had stage 3 or worse kidney disease. Patients with very high blood pressure or serum creatinine over 4 were excluded from the study. 933 patients were analyzed from the 944 randomized. Over 5,000 patients were screened. The original design called for 1,080 patients. Because of slow enrollment, the requirement for hypertension was dropped, the follow-up was extended, and the number enrolled was decreased by about 10% below that target. The CORAL study was intended to address some of the shortcomings of the 5 prior randomized studies of renal artery stenting. This included studies that enrolled patients with mild stenosis or stenosis without a gradient. Some studies were contaminated by crossover. Presumably, these were patients who were doing poorly on medical therapy, who were clinically stented. This tends to make the medical therapy look better and make the stent cohort look worse. Some of the prior studies had high complication rates and utilized low experience operators. In the CORAL study, the stent complication rate was about 5%. Prior studies did not mandate the extensive optimal medical therapy that the CORAL study did. And prior studies focused on blood pressure and renal outcomes rather than clinical endpoints. So, renal artery stenosis is supposed to replicate the physiology of the Goldblatt kidney. In the 1930s, Harry Goldblatt showed that an ischemic kidney in dogs leads to hypertension. This led to the discovery that kidneys regulate blood pressure by secreting hormones that cause hypertension through vasoconstriction, sodium retention, thirst, etc. Keep in mind that we suppose that this renal artery stenosis is an upstream event that is eventually mediated by hormonal stimulation of the angiotensin receptor. There are other organs, other pathways, other redundancies that regulate blood pressure because this is a central physiologic variable. With no blood pressure, there's no life. There's a vast potential gulf between an anesthetized, acutely instrumented dog and clinical practice. So this shows the outcomes of the primary endpoint. Over 5 years, about a third of the patients had bad things happen to them. Nearly half of those bad things were progression of renal insufficiency, but there was no difference in outcome between those who were stented versus those who were not stented. The outcomes for all the subgroups was the same. This includes patients who had impaired renal function versus unimpaired renal function, a blood pressure greater than 160 versus less than 160, and tight renal artery stenosis versus a less tight stenosis. So there was no discernible effect on cardiovascular death, stroke, myocardial infarction, heart failure, chronic kidney disease, dialysis, or hypertension. As regards blood pressure, technically, yes, there was a statistically significant p-value 0.03 difference in blood pressure between the two groups. This is 2 millimeters pressure overall. My take on this would be that the statistical power of analyzing a continuous variable like blood pressure in nearly 1,000 patients is enormous. This is a statistically significant but not a clinically significant outcome difference. The blood pressure came down about 15 points in both groups. Both groups ended up on about 3 blood pressure medicines. So the conclusion for the CORAL study and the patients in it was that adding stenting to medical therapy had no clinical benefit. Why might this be the case? Well, there's the usual criticisms that it's hard to make a difference if the patient does not have a significant severe stenosis or if their blood pressure coming into the study is normal. There was not enough that they didn't meet their target projected number of patients, and would this have made a difference in some of the subgroups? Optimal medical therapy is improved, and in particular, using an ARB may block the downstream effects triggered by the upstream stenosis through this final common pathway. Very few patients with renal artery stenosis are a pure Goldblatt kidney model. Almost all of them are on blood pressure medicines and continue to be on blood pressure medicines. And our elderly patients, for the most part, are a lot different than a young and otherwise healthy dog used in a Goldblatt preparation. And finally, there may be a standoff between the benefit of having a stented artery versus the complications of embolization, contrast toxicity, and other problems from the procedure. So, is renal artery stenting dead? My sources in the industry say that the volume of renal stenting is down about 25 or 30% since the CORAL study was published and continuing to decline. I would agree that renal stenting is rarely indicated for renal artery stenosis with controlled blood pressure and good kidney function. It's also not needed for patients who have closed the barn door. In other words, they already have atrophy or they already have end-stage renal disease. You can only get complications from trying to open a chronically occluded renal artery. Patients who have moderate clinical disease, that is, they're not too sick from their renal artery stenosis, and who have challenging anatomy where the chances of complications are higher, are rarely indicated for treatment. So, current status of renal stenting. I would still consider it for fibromuscular dysplasia, patients not included in CORAL who are often cured by treatment of the blockage. For patients who have resistant hypertension, for patients who are non-adherent, I mean, does anyone else here have patients who won't take their pills? You know, the compliance rate for renal artery stenting is 100%. Patients with bilateral disease and acute decompensation, transplant artery stenosis, renal artery stenosis in a single functioning kidney, global ischemic nephropathy, all fall under the heading of having their entire renal mass in jeopardy because of a tight stenosis. I would consider these on an individual clinical basis because we still have to keep in mind that in the CORAL study, of the 20% of patients who had global ischemia, there was again no discernible difference in outcome for those stented versus not stented. Finally, we may consider, again on a clinical basis, treating patients with malignant hypertension that results in heart failure. These patients were also not included in CORAL. So my bottom line on CORAL is that in patients who have moderate atherosclerotic renal artery stenosis, who aren't too sick, use medical therapy first. Thank you.
Our next speaker is well known in the field of endovascular and a pioneer in critical limb ischemia. Dr. Craig Walker is the founder and director of Cardiovascular Institute of South, and it gives me great pleasure to introduce him to give us our next talk. Dr. Walker?
Thank you, Dr. Kumar. Dr. Golzar had asked me to speak on a history of renal denervation, and so when I saw the subsequent talks that are going to follow mine, I've amended this just a bit to hopefully not step on toes. I will mention a couple of the prior trials, but only briefly from a historical perspective. In terms of disclosures, I am one of the investigators in Boston Scientific's VESIX trial on renal denervation. Now, if we look at the sympathetic nervous system and how it affects kidney function, we have to go back all the way to 1664, when Thomas Willis, a British physician, provided the first anatomically correct depiction of the sympathetic nervous system. In 1727, Paufoy de Petit was credited with the first suggestion of neural control of blood vessels. He did a cervical sympathectomy and noticed conjunctival vessel dilation. In the mid-19th century, Brown-Sequard and colleagues demonstrated that there was neural circulatory control by vasoconstriction with electrical stimulation of cut nerves. In 1842, Carl Ludwig described sympathetic nerves surrounding the renal artery. And in 1946, von Euler definitively demonstrated the sympathetic transmitter to be norepinephrine. Now, the anatomy of the renal sympathetic nervous system is very important to understand because we have afferent and efferent loops. And if we look at these, the postganglionic efferent fibers originate in the hypothalamus, and they run out to the kidney via pre- and paravertebral sympathetic ganglia that are located at T10 and L2. Via the ipsilateral dorsal root ganglia, T6 through L4, there are afferent pathways that ascend to the autonomic centers of the brain and to the contralateral kidney, allowing cross-regulation of renal hemodynamics. Now, in addition to that, we have the efferent and afferent nerve fibers, which lie in the adventitious of the renal artery and can be seen here very nicely. Now, renal efferent sympathetic nerve activity decreases renal blood flow and glomerular filtration rate. It increases tubular sodium and water reabsorption, and it increases renin release. The afferent renal nerves are really related to the mechanoreceptors in the renal pelvis, which sense stretch, which is hydrostatic renal pelvic pressure and renal arterial and venous pressure. There are chemoreceptors that are activated by renal ischemia and changes in the biochemical milieu. There's stretch activation of afferent fibers, which elicit an inhibitory renal reflex response, and this leads to natriuresis and diuresis. And finally, it provides cross-regulation of the contralateral kidney. So we can see these things all working, and we understand that this is really a complex feedback system that affects blood vessels, it affects insulin release, it affects many different things, ultimately resulting in blood pressure control. So how does this play a role in hypertension, and why would we want to regulate this? What would we hope to achieve? Well, to start with, it's very interesting when we look at hypertensive subjects, we see that they actually have 4 more nerve fibers in their adventition than people who are normotensive. And you can see that here on this slide by Sanjigorgi. Now, if we go back and we take a historical purview, the very first surgical sympathectomy for hypertension that I could find was a case that was reported in 1934 by Page and Hoyer on a 23-year-old female who had a systolic blood pressure of 200 that they could not control. They sectioned the anterior nerve roots from the 6th thoracic to the 2nd lumbar segment. This resulted in rapid normalization of the patient's blood pressure. However, the abdominal muscles were paralyzed. It was interesting as I read this article that the author stated she soon learned how to manage the motion of her trunk without the use of her abdominal musculature. I'm not sure that would go over very well in today's world. But really who changed this whole field was Dr. Reginald Smithwick. Dr. Reginald Smithwick in 1953 published this seminal article, and it was a large series of essential hypertension patients treated with thoracolumbar splanchectomy. And you can see that he demonstrated in these patients improved survival. They had better blood pressure control, and they clearly had improved survival. However, and there were a lot of benefits derived from this. There were profound improvements in the blood pressure. There was reduction in the cardiac size. There was improved renal function. These patients experienced a lower incidence of headaches. They had reduced chest pain. They had lowered cerebrovascular events, and they had a reduced mortality, as I've mentioned. Problem was there were a lot of pitfalls. There was significant operative and morbidity and mortality. There was a prolonged post-operative hospital course. There were disabling complications. There was severe orthostatic hypotension, as well as problems such as anhidrosis, atelectasis, intestinal disturbances, erectile dysfunction, which is probably what killed the whole thing, and urinary and fecal incontinence. So the advent of safer, orally active antihypertensive agents really led to the abandonment of this procedure for treating hypertension by 1970. Nevertheless, this technique highlights the intrinsic relationships between the sympathetic nervous system, kidneys, and blood pressure regulation. Now, in addition to this, there were observations made from patients with kidney disease undergoing renal transplantation or nephrectomy and animal models of renal sympathectomy. Overactivity of the sympathetic nervous system in patients with end-stage renal disease was present. Post-renal transplantation, this persists if the native kidney is not removed. Removal of the diseased kidney leads to blood pressure normalization, and afferent fibers were felt to be responsible for this effect. Now, there are also chemical mediators and other studies that we can have that suggest that there is a relationship to the sympathetic nervous system. If we look at controls in hypertensives, we can see that there's more release of noradrenaline. If we look at muscular sympathetic nerve activity, we can see that it is increased in the hypertensive patients, and there's a higher rate of spillover, of noradrenaline. So a lot of methodologies have been addressed looking at trying to disrupt this, this nervous control of blood pressure. The most common is commonly used thus far and most studied has been radiofrequency ablation. However, there are other modalities being evaluated, ultrasound, both internal and non-invasive from external sources, cryoablation, as well as pharmacological methods to try to destroy or disable these nerve fibers. You can see that many companies got into this, and of course the first was Medtronic, and they did the Simplicity trial, but there were a whole lot of companies that jumped in, and there are far more companies than this now. These were just some of the first to get involved in pursuing the concept of renal denervation. So I think it bears importance, if we're going to speak of the history of this device, is to really talk about the first device that was used, and that was the Simplicity catheter, which was created by Ardian. The original device was developed by Mark Gelfand and Howard Levin around 2004. It's about a 40-minute procedure, and you can see that there were a series of spiral burns made using radiofrequency ablation. This was a unipolar radiofrequency electrode. Low power, 5 to 8 watts, was used. And with this, blood flow tended to minimize endothelial injury, and there were focal ablations to allow for rapid healing. We can see that in these studies in pigs that there was really very little injury to the intima after this procedure, and it appeared to be safe. However, you can see that in these same porcine models that there was disruption of the periadventitial nerves, as shown here. And we can see that in this preclinical efficacy and safety study that denervating these renal arteries resulted in a similar response in terms of the release of norepinephrine to actual surgical denervation, and it was safe in this porcine model. So you can see here early clinical experience. This was looking at what happened with the Ardian device in humans, and you can see that it did indeed affect muscular sympathetic activity, and there was a diminished release of these neurotransmitters. So Simplicity came along. It was a first-in-man study. You've probably all read this trial at one point. And it created a lot of interest because there was a tremendous drop in blood pressure, as shown here. This persisted, and there were all sorts of other things reported in this group. And there was really excitement. This was going to be the way to treat heart failure. It was going to have effect on diabetes. Then along came a randomized controlled trial with a sham arm, Simplicity 3, and this really kind of doused a lot of that initial enthusiasm. I'm sure today's subsequent speakers are going to address why this may have failed, and it may not even be a problem with renal denervation at all. It may have been execution or patient selection, or it may indeed represent something creating concern. But I think in conclusion, it's important to understand that hypertension is a major health problem, and it contributes to substantial morbidity, mortality, and cost, and it results in people having to take a lot of medicines that make them feel bad. Renal sympathetic activity, both via efferent and afferent nerves, plays an integral role in blood pressure control and has to be a target of therapy. Secondary effects of chronic renal sympathetic overactivity can lead to multiple groups of pathological and clinical sequelae, such as cardiac disease, metabolic syndrome, sleep disorders, etc. Despite the disappointing results of Simplicity 3, catheter-based renal denervation was shown previously to have substantial benefit, and there are studies ongoing now to try to determine if indeed that is real. And with that, I will end this talk. Thank you for your attention. Next, I would like to ask Dr. Ian Meredith to come up and show us a taped, oh, I'm sorry, is that not next? Yes. Dr. Ian Meredith, come up and show us a taped case of renal denervation. Is Dr. Meredith here?
Well, good morning and welcome to Monash Medical Centre. This is Monash Heart and I'm Professor Ian Meredith, the Director of Monash Heart, and I'm joined today by Dr. Ben Dundon, a close friend of mine and a very accomplished interventional cardiologist, and of course our scrub nurse Anna Petrakos. It's our great pleasure to demonstrate to you today the use of the Boston Scientific's VESIX renal denervation system.
So the case we'll be presenting today is a 52-year-old woman who has a long history of hypertension, increasingly resistant to pharmacotherapy in recent years. She has evidence also of end organ disease with moderate concentric left ventricular remodelling and early aortic root dilatation. She has a past history of ischemic heart disease with coronary interventions, as well as hyperlipidemia, and is thankfully an ex-smoker. She has a strong family history of cardiovascular disease dating back 3 generations and has had previous lap band surgery for obesity. In terms of her medications, she is currently taking antiplatelet agents in the context of coronary stenting and is on 5 antihypertensive agents, including an angiotensin receptor blocker, thiazide diuretic, calcium channel blocker, moxonidine as a centrally acting adrenergic inhibitor, and spironolactone. We do note that she is taking desvenlafaxine, which is obviously not ideal in the context of hypertension, but her hypertension predated the use of this agent, which she needs for clinical reasons. Her average office screening blood pressure is excessive at 185/90, and this is consistent with her daytime 24-hour average blood pressure on ambulatory monitoring. She also has a significant nocturnal blood pressure burden with an average nocturnal blood pressure of 150/75. As mentioned, she has an increased BMI of 38.7 but has normal renal function, and ECG shows characteristics of left ventricular hypertrophy by voltage criteria. She has previously had serological and imaging exclusion of secondary causes of hypertension, and renal ultrasound in October of 2013 revealed no evidence of parenchymal or vascular issues that would contribute to her hypertensive burden. You can see here the results of an ultrasound of her renal tract in 2013, which revealed a symmetrical kidney size with normal corticomedullary differentiation and no obvious renal parenchymal issues. There was certainly no evidence of significant renal artery stenosis or any signs of a vascular issue contributing to her blood pressure burden. So as seen on the renal CT angiogram, we see a single renal artery bilaterally with comparable diameters, 48 millimetres of the right renal artery and 47 on the left. You can see in the top right panel of the multiplanar reconstruction of the right renal artery that there is atheroma within this artery, particularly present in the midpoint, but causing no more than minor stenosis. The length of the right renal artery is 43 millimetres, potentially sufficient to allow 2 treatment zones, as we'll discuss in a moment, and approximately 50 millimetres in length from ostium to major bifurcation of the left renal artery. You can see here we've got volume rendered tomographs of not only the renal angiogram, but also extending down to the common femoral and in fact femoral bifurcation. Although we appreciate that not all centres may undertake such studies prior to the procedure, we find it invaluable in our pre-procedural planning and assessment of the common femoral anatomy as well as iliac tortuosity, and allows us to begin to decide about the kind of catheters that we might use at the time of the procedure. The other great value of an extended field of view with the CT angiography is that we can exclude any accessory renal arteries that perhaps may arise from the distal abdominal aorta, and you can see here that there are none in our case today.
So here are the RDC guiding sheath images of the right renal artery. And as you can see, there are very small suprarenal branches coming off proximally near the aorta, and we won't worry about those. There is overlap from another vessel that does look like it's arising from the main renal artery, but it is not. It's a separate vessel. The renal artery has about 50 millimetres out to the primary trifurcation, and you can see there is a slight degree of atherosclerosis in the vessel after the main tortuous bend, so we have to be fairly careful with that. The sit of the guiding catheter was not particularly different between the RDC and the IM in this specific artery, so we're sticking with the RDC.
So just while Ian's shaping the wire, as we mentioned before, we're taking an 018 through-way wire for this procedure. We had experience using 014 stiff wires, but in fact we find the 018 to be far superior and would strongly recommend that for your cases. The wire we have today, the through-way wire, is specifically used in peripheral intervention. It has a 5 centimetre distal floppy tip and an 11 centimetre transition zone to its core, giving us quite a great deal of support as we bring the balloon catheter into each renal artery. So we can see here the 5mm Vessix Reduce balloon catheter that we'll be taking today. 25mm, as I mentioned previously, is the balloon length. The treatment zone is 21mm. We'll take the catheter out of the box now and we'll talk you through each of its components. And you can see here that it comes with 3 ports, just as any other over-the-wire system: the central wire port, inflation port, and of course the treatment delivery port. But after we've taken the balloon catheter out of its packaging, it comes with a central stylet which is removed, a protective sheath that covers the balloon and its associated electrodes, and of course, as previously mentioned, the energy delivery port that will pass across to the console once we move across to the table. Of course, we're always very keen to undertake the preparation of the device consistent with the IFU, which states that we should take a 10 to 20mm syringe with a 30-70 contrast saline mix, aspirating slowly the catheter and releasing tension slowly to gradually allow filling of the balloon passively from the insufflator. We're now going to take the balloon catheter up to the patient and introduce it over our through-way guide wire.
So we now have the system loaded on the through-way wire. We're just going to open the TUI Borst at the end of the guiding sheath and introduce that. Now, of course, when you open a TUI Borst on the end of a 7 French guiding sheath, there is a lot of backflow, so you need to do that very carefully not to lose too much blood.
So the TUI Borst is open, that's the reason for the pressure trace.
Yeah. And you have to have the TUI Borst open a reasonable amount to allow the balloon to slide through the guiding sheath. And here you can see on the live fluoro image, I've backed the guide back to make a nice arc, and you can see here's the balloon coming through the guiding catheter and into the vessel. And you see you get a great deal of support from the through-way wire, so it's very, very nice. And I think just on the kidney silhouette is about where we want to go. And the guide's backed up a little bit, but that won't matter. Just take that in, just run the wire a little bit further forward for a second. There we go. That's great. And just close the O-ring down a bit. And we can see the electrodes very clearly.
So we're inflating at 0.5 atmospheres increments.
You can see the balloon expanding now. And that looks like a reasonable size already, given the atherosclerosis. And you can see that all electrodes are in contact now, and that's at 1 atmosphere. 1 atmosphere. So there's probably no point going any more than that. The balloon's expanded well, and all of the electrodes show contact. I'm quite happy with that appearance.
We'll take a puff of contrast here, and then we'll begin treatment.
Yep, we've got no flow whatsoever, and I think we're probably ready to go. So
Andrew, it's going to get
And here we are
uncomfortable.
delivering the energy now for 30 seconds. And what's very nice about this is a simultaneous release of energy from all of the electrodes. It is a little bit painful, and you do need to have the patient adequately sedated with analgesia and pain relief, analgesia and sedation. And you can see we've reached 68 degrees, and there's 7 seconds to go. So it's very effective, very efficient, and all 6 electrodes are fired.
And that's complete.
30 seconds, that's great. So we're going to let down the balloon very slowly, half an atmosphere at a time. This is a nice example of not needing to use the full 3 atmospheres to get the balloon correct. Okay? And
that's down to 0 atmospheres.
That's right. Now, I am going to now just simply record that position. I want now to have the proximal electrodes 3 to 5 millimetres proximal to the most distal electrodes when we do our next inflation. And of course that might mean that some of the more distal electrodes on this balloon will be actually hanging out with the aorta, but I think that's probably okay, Ben. So now just using over the wire, I'm just going to move this back, and I've got my nice reference image on the other screen to see that. If you look there, I'm using the visual landmarks of the vertebral bodies, and I think I'm pretty good position there. What do you reckon?
I think that's good. We may end up bringing the catheter back a little.
Yeah, I think so. We need to bring the guiding catheter back, which means we'll be out of the vessel ever so slightly. Even more. Just close the O-ring down, get the pressure trace back. Let's just have a little puff there. Now we may not see much here because the catheter is now hanging out. Yeah, but that looks pretty good, actually. That looks really good. So let's just come back even. I've got room to come back even a fraction further, which I will. And so let's gently inflate there again. Just opening the O-ring so I can just reposition the guide a little.
So we're just inflating again at 0.5 atmosphere increments.
Yeah, very slowly inflating.
So we're at half an atmosphere now, and you can see that the balloon is beginning to expand, and as we approach 1 atmosphere, again, we're just giving it time to fully expand the balloon catheter.
And because of the takeoff, the balloon, one of the proximal electrodes, as you can see, or two, yellow, have not completely changed colour. So
might go to 1.5 atmospheres.
I'm not sure I do too much because of the slope of the vessel, I just don't want to damage the ostium of the vessel. So that looks pretty good to me for size. So that's 1.5 atmospheres, is it?
Indeed. So,
we've got 4 electrodes there. So we're going to end up with 10 treatments in this 50mm segment. So I think that's very effective. So let's just...
short puff of contrast.
Short puff of contrast.
There's no flow in the vessel.
No flow in the vessel at all, but we're not contacted with 2 electrodes. Okay, I think, are you happy to go?
Let's treat.
In fact, 5 of the 6 are now in contact.
The yellow, as you can see on the console there, indicates that there is incomplete or perhaps only partial apposition. That doesn't mean that treatment or that electrode won't fire. In fact, when we reach 12 seconds and have now passed it, we can see that 6th electrode actually did have sufficient apposition to allow treatment. And hence we're getting 6 treatments in total on this occasion, as well as 6 previously, so 12 in total for this vessel.
2, 1, all over. Well done. Excellent, excellent. I know it's a little bit painful. Almost seems a little bit more painful at the ostium, doesn't it?
It does. And just coming down a little,
because
very
of
slowly.
aortic innervation, perhaps. But now, if you could just short exchange while I move the guide forward, just slowly, slowly get the balloon out, just very slowly. There you go, and the balloon is out. Keep going. I'll just take the balloon forward over the guide. There we go. So let's take a final shot just to see what it looks like after the 10 treatments. That looks pretty good. There's a little bit of kinking there from the wire as the wire comes out of this tortuous vessel, but the vessel looks like otherwise in pretty good shape. So I think actually we can gently retract the wire now into the guiding catheter, and we'll just flip this round to the other side, I think, and we'll see how we go. So given the position then and the length of the straight segment of the vessel before that branch, probably might be nice just for one single 25mm balloon inflation right in the middle of that and get all 6. What do you think?
I think we will. I think on the CT we thought we'd be able to get 2 nice clean treatment zones, but actually on the basis of this, I think one good one proximal to that small branch is going to be perfect, I think. Right,
and we'll centre the balloon over that tiny little suprarenal branch that we can see there. So, okay, I'll just open the O-ring and move the balloon forward. Now, we have not taken the balloon out of the body or the guide, we just flipped it from one side to the other. Just opening the O-ring now, and you can see here's the balloon in the guide still. And we've got nice position with the wire in that superior branch. And that should be about right, I think. I'll just close the O-ring down and get Ben to take a shot. Have a look there. I'll come back a bit, actually, Ben.
Yeah, I've got room too.
Yeah. Let's test that. Yeah, I'm pretty happy with that.
That looks good.
All right. So again, let's inflate that balloon very slowly. You saw last time we only needed 1 atmosphere in order to get contact. All right, Ben, so we're in a good position. You want to inflate that balloon now. And we'll concentrate on the contact on the console and see how that matches up with the inflation pressure.
So we're at 1 atmosphere there, and you can see the balloon beginning to inflate.
So
just moving now to 1.5 atmospheres. We can see that only the 3 most distal electrodes are currently in full contact. So I've taken it now gradually to 2 atmospheres. And certainly angiographically, it looks as though we have quite good apposition.
So there's the balloon, and what are you up to now?
So we're up to 2 atmospheres, and you can see on the console that the 3 most distal electrodes have very good apposition. The 3 more proximal electrodes are coloured yellow on the console, which indicates that their apposition is, that they have apposition, but that the apposition is perhaps not optimal in comparison to the 3 more distal. Now that may relate to the tortuosity of the vessel, and of course the non-compliant nature of the wire and balloon systems can obviously distort the vessel architecture somewhat, so that the electrodes may or may not be in contact across the full length of the balloon all the time.
So what we might do then is an angiographic confirmation by giving a selective injection and seeing if we can get any flow around the balloon that might suggest we need to reposition. So here we go, we'll just put a small amount of contrast in and absolutely no flow in the vessel. So we really have 2 options, either deliver the therapy, in which case all electrodes may actually come good, or indeed we could move the balloon slightly more distally in the vessel. But I think the best thing to do is treat where we are.
As mentioned previously, it takes approximately 12 seconds for the temperature to ramp up to 68 degrees, and we'll know at that point as to whether those 3 more proximal electrodes are going to remain whether they provide treatment. And we are.
We're getting all 6. Yeah, so all 6 are actually treating. So the contact was suboptimal, but it was still in the range that was going to be effective.
Indeed.
So it's rather than move the balloon around, and there it is, we've done all 6 treatments. Excellent, thank you.
We're now going to release the balloon tension gradually.
Okay, so come back live and you'll see the balloon just very slow. I'm just going to move the guide back a little bit. We had a really nice position there. So I'll just move the guide back temporarily just to allow the balloon to come down, and Ben's deflating the balloon slowly. And you see what great support we've had from the throughway wire. It's been really good.
You can see the electrodes re-wrapping there as we come down slowly, and that's a really important component of the procedure.
So I've just opened the O-ring ever so slightly, the pressure's going away, and if you could just short exchange the balloon back into the guiding catheter, and I'll take the guiding sheath forward. That's good, that's all right. Now pull the balloon back a fair bit now. You're going to say a bit of resistance?
There's minor resistance, you can always feel it.
I think I was holding it for you. There you go, and certainly no injury or damage done to the vessel, and we've clearly see we've treated proximal to that first branch of the terminal bifurcation. So good result, no dissection, and certainly no adverse effects to the vessel. So I hope you've enjoyed today's presentation and you found it informative. As you know, we have demonstrated for you the Boston Scientific VESIX renal denervation system. We used the 7 French BSC guiding sheath, the RDC format, an 018 throughway wire, and the 5mm 6 electrode balloon. We delivered 12 therapies into the right renal system and 6 therapies into the left renal system for a total of 18 therapies. So once again, thank you very much for joining us today, and Ben, your expert commentary and assistance with the procedure, and Cara and indeed Anna for assisting us. And I hope if you found this procedure, as demonstrated here at Monash Heart, to be useful in your practice.
Great. That's a very nice demonstration of the device being used in the present ongoing trial in the U.S. by Boston Scientific. Next, it's indeed a pleasure to introduce a real giant in the field, Dr. Michael Jaff, who's going to speak on renal denervation for hypertension, clinical updates, and future directions.
Thank you. Thanks, Craig, and thanks to the organizers for inviting me. Just a couple of highlighted notes. In the past, some of my interventional colleagues have told me that watching a live renal denervation case is like watching paint dry. But actually, that was pretty interesting and well done. And also, I want to congratulate Craig. That was the finest historic review of this field that you'll hear. And it certainly gives us some pause to think about what did we do wrong, and is there an opportunity to go forward? And that's what I'm going to try and do over the next couple of minutes. These are my conflicts of interest of relevance to this talk. I do provide advice to Boston Scientific and Medtronic, but don't receive compensation for that advice. So you get what you pay for kind of thing. And I'll be discussing their strategies in this field going forward. You've already heard a lot about this, so I won't spend much time, but I want to remind you of why we spent so much of an effort on trying to figure out better ways to manage hypertension. Cardiovascular mortality doubles with each 20 millimeter or 10 millimeter increase in systolic and diastolic blood pressure, so that's a serious issue. A modest reduction in blood pressure has a significant reduction, as you can see, in major adverse cardiovascular events, cardiovascular mortality, and all-cause mortality. And according to the World Health Organization, hypertension remains the leading cause of death and disability worldwide. And most hypertension is really not well controlled for a whole multitude of reasons. Now, I'm not going to spend a lot of time how we define resistant hypertension, because as we move forward in this arena, we're actually changing our thoughts about what patients may be best suited for renal denervation. But understand that the true definition of resistant hypertension is inability to adequately control blood pressure on at least 3 antihypertensive agents that make sense to be used together in maximal tolerated doses. Now, there's been a lot of effort on sympathetic denervation for resistant hypertension. You heard some of this already. I'll cover some of this, and then subsequent speakers and discussions will review this. And Craig did such a great job that I'm going to skip over that. But when you see why we got so excited, and I will plead that I was, in fact, as much of a criminal to all of this as anybody, I stood up at every meeting I was given a chance to say that this will be the most revolutionary advantage for our patients that I will see in my career. I mean, I'll admit it. I said it over and over again. And it was because of data like this. Craig showed you this. This was the 3-year data published in a very esteemed cardiovascular journal, Lancet. You can see very serious hypertension on at least 5 medications. The majority of these patients were on a diuretic, so well-defined for treatment. And in fact, there was a dramatic and durable reduction in both systolic and diastolic blood pressure in this non-randomized experience in patients with really bad hypertension. Hypertension we probably can't control very well on more than 5 medications. And you can see here that when you look at the proportion of patients who actually went from a blood pressure of 180 or greater down to a blood pressure of less than 140 out to 36 months, it's truly startling. How could you have thought this would not have worked? So the treatment response showed that the majority of patients, 93% of patients, had a systolic blood pressure drop of at least 10 millimeters of mercury at 36 months. So this wasn't just a flash in the pan. So clearly, radiofrequency ablation for resistant hypertension works, right? Well, the world changes. This announcement came as the shock around the world, January 9th, 2014, when Medtronic announced that it was stopping its U.S. pivotal trial because it failed to meet the primary endpoint. It didn't have a safety concern, but it concluded that there was no advantage to denervation. And then a few months later, as Craig suggested earlier, the New England Journal published this right at the start of the American College of Cardiology meeting. I remember this was all the talk. This was, again, a well-designed, well-run trial. The difference, of course, was that this was a truly blinded, randomized, head-to-head trial. In fact, you realize that the control arm actually had an arterial puncture with a catheter placed in the artery. And the only difference was that energy wasn't delivered. So there was no way that the patient would have known, unless, of course, somebody broke the blinding. You see here that at baseline, the number of antihypertensive medications were at least 5, which persisted out to 6 months. Here's the data that Dr. Walker already showed you. There was no difference in patients who received active treatment versus a sham procedure in their systolic and diastolic blood pressures, and there was no difference in the change in blood pressure over time. So we went from simplicity to complexity. What the heck now? And if you wanted to see what happened, what does an investor have to do to support research in the field? This entire field shut down. I've never seen anything like this. at least 30 companies lost their funding. And major companies really spent a lot of time trying to figure if this was even worth being in the game for. Well, give credit to the two that are still working on this actively and publicly, and that is Medtronic and Boston Scientific. They looked at where these problems might have existed and what could have been done differently. And I have to admit, when you look at this Simplicity HTN-3 data, and I'm not going to go over this in detail because the subsequent speaker is going to give you a lot more about this, it's pretty shocking that we didn't think about this stuff ahead of time, I have to be honest. There were issues around drug changes, doses, drugs, et cetera, and patient adherence. No surprise to those of you who take care of patients in the real world like I do. The study population might not have been the best one. And interestingly enough, for something in which interventionists say these are chip-shot procedures, experience and variability in performing the procedure may have had a significant role to play. So this is just looking at the change in medications on patients enrolled in Simplicity HTN-3 over the course of time. It turns out that 40% of the subjects had changes in their medications between baseline and at the primary endpoint. A lot of these changes were due to adverse events related to the medications. And it turns out that if you look in the antihypertensive pharmacologic trial literature, the way we did this study was really not the best way to do it. It turns out that in pharmacologic drug trials, they actually do these where patients are actually stopped from taking their medications, and then, so a washout, and then followed over time off their medications compared to the index-treated drug. So it turns out these washout periods range anywhere from 2 to 4 weeks. The time off the medication, 16 to 20 weeks. I have to admit, many people said to me, I would never let my patient in a trial like that whose blood pressure is high on blood pressure medication. But that's exactly what multiple studies have done. And it turns out there was no difference in safety in those patients who were on medications and washed out and those randomized into a drug. So these are accepted as ethical and safe by ethics committees, institutional review boards, and the Food and Drug Administration. So actually, when you look back on this, here's the data. These are reviews of all the short-term placebo-controlled trials in a 30-year period of time, 590 trials, 86,000 randomized patients, as you can see, 22,000 about with placebo. And just looking at the event rates, cardiac events and irreversible harm, which of course includes major stroke, this reveals that there's no objective reason to conclude that the use of a placebo in a short-term antihypertensive trial should be discontinued. It actually is a safe practice to do. Now, what about procedural experience? Well, it turns out that more than 50% of the interventionists in the Simplicity HTN-3 study performed fewer than 2 renal denervation procedures, yet in the global Simplicity registry, about 2/3 of the interventionists performed more than 15 of these procedures. So that may have an issue. Craig's already talked about this. I'm not going to spend any time other than to suggest that not only do we think that there's a difference in the number of adventitial sympathetic nerves, but there's a difference in the location and the closeness of the arterial lumen to these renal nerves, and it may be more distal than we thought. In fact, in one small internal study, those patients who were treated with renal denervation both in the main renal artery and the branch renal artery had a better result. So, this led to 2 major efforts to rejuvenate and restudy the impact of renal denervation. One is by Medtronic in the SPIRAL series of studies. This is a global study looking at these 3 errors or potential misses in Simplicity HTN-3. There are 2 phases to this. The first phase is actually ongoing. 2 parallel trials, 20 sites globally. There's the SPIRAL HTN off-med study and the SPIRAL HTN on-med study. Both are sham-controlled, 100 patients in each. Notice that the main renal artery and branch ablation is expected to be performed. There are no specific medication requirements in the off-med study. In the on-med study, no maximal tolerated dose is actually allowed, and they're looking at ambulatory blood pressure. Depending on the results of those 2, it will lead to a SPIRAL HTN pivotal study, which will include things like cost effectiveness. Now, you've already seen a beautiful example of how to use this Vessix renal denervation system, but Boston Scientific has a similar plan with a very large series of studies in the REDUCE-HDN clinical series. And in this, specifically for what we're going to talk about, the REINFORCE study, which is enrolling, is looking to demonstrate the effects of renal denervation in the absence of confounding antihypertensive medication. So again, washout, pure randomization with no impact of medication changes. I won't walk you through all of this, but you can see this is really a beautifully done 2-to-1 randomization scheme. These are patients already being enrolled, very rigorous follow-up, with a primary follow-up period of 2, 4, and 8 weeks, with procedural safety assessments and ambulatory blood pressure monitoring. So where is this today? Well, the complete 180-degree loss of interest is really starting to fade, I'm happy to say. Exuberance prior to the release of Simplicity HTN-3, like my own, has been replaced by opportunities to do real science to figure this out. There are important ongoing feasibility trials. And one more quick thing, don't forget this. This is the ROX arteriovenous coupler. Imagine this. A very well-known vascular surgeon who's highly regarded said at a national meeting, "I've seen a lot of boneheaded things in my career, but this one takes the cake." And in fact, this study, which actually looked at an arteriovenous anastomosis deliberately made, showed that when you open up this connection, there's an on-the-table dramatic reduction in blood pressure. When you close it, the blood pressure immediately goes up, proving at least that this may do something. Well, this has actually been published again in Lancet. Lancet seems to be very interested in all of this. And just quickly to show you, this data was pretty impressive. You can see here that these were patients who had significant hypertension, ambulatory blood pressure systolic of 157. And notice those patients who were given the arteriovenous coupler device had a much more impressive reduction in both systolic and diastolic blood pressures than those who were not. Thank you very much.
Thank you, Mike. Very nice presentation. Our final speaker of this session, and we're going to change after and just change the panels, no real break at that point, is a great friend, a wonderful speaker, Dr. Mark Goodwin. Mark is going to speak to us on Simplicity Hypertension. Now that the dust has settled, what have we learned? Mark?
Thanks, Craig. Thanks, everyone. Hopefully not too much to overlap with what the other guys had already covered. Whoops. Someone went over my consultant. From a disclosure standpoint, I was a Hercules investigator, a Simplicity investigator, and currently in the Artisan trial. Super Bowl, I was here. Bears Colts, Miami. Hess runs back the touchdown. I go nuts. Colts win 29-17. What happened? Well, this is similar to what happened with all of us. And I think what I learned most through this trial is more about us than it necessarily is about the information. So information was coming at us every single day. Lancet published a landmark study, as Mike alluded to, and we were all off and running, all about renal denervation. So everyone knew that it worked. Sorry about that. Everyone knew it worked. Industry purchase of startups were at incredible valuations. Physicians were demanding, not really knowing whether it worked or not, that they had access for their patients. Press release on a daily basis, medical meetings, TCT, Link, Craig's meeting, Mike's meeting, full days dedicated to RDN, and rooms were packed. What happened? Sort of like the Bears, huh? Well, there's two types of errors in trials that we all need to take ourselves back to. This is out of Francis' work, type 1 error. The hypothesis is fake, but by chance, the result meets the criteria for statistical significance. That would be an alpha error. And then on the type 2 error, the trial hypothesis is true, but by chance, the result does not meet the criteria for statistical significance, which we call beta error. Now, this requires sample size and what all the biostatisticians do. But the reality is we can be wrong either by the sign, which is whether it was positive or negative, or the magnitude. So when we look at this is not the first time we've been here. I'm older than most of you in the room. We all knew that treating PVCs was absolutely the thing to do until trials showed by the CAST investigators that people died when we treated their PVCs. And of course, not to go down sympathetic tone, monoxidine clearly was going to work. It depressed the sympathetic nervous system. Blood pressure in blinded studies was reduced by 13, better than placebo. It was going to be the heart failure drug. It cut norepinephrine levels in half. And then we began to do a study. And at 1 year, the trial was stopped, 42 versus 24 deaths. So we've been here before. Survival was worsened, and it died. We all knew, of course, that beta blockers work for surgery. This is a type 1 or 2A indication from about 98 through about 2005. Every study, we knew that it worked because it decreased infarcts. But after recent revelations, a closer look gave us less reassuring data. Myocardial infarction is reduced, so we all said it had to work because we're cardiologists, right? But stroke was increased, hypotension was increased, and mortality was increased. So it's not like we haven't been here before. So what happened with renal denervation? Well, I don't know. If you take a poorly defined population with no evidence that it worked, and people who've never used it before, and don't know whether you're successful, I'm really not sure what you think could go wrong. Now, that's all retrospective. I, like Mike, was excited about it. I thought for sure it was going to work when I was an investigator for it. But retrospectively, I think a little too much haste for all of us. So what should we do better? Mike touched on some of this. RDN catheters result in energy. The depth of energy needs to get to about 70% of nerves. So if you look at the data, and Dave Canzeri talked about this at EuroPCR, of operator experience, Mike alluded to this, 50% of operators performed less than 2 procedures. So that's not a good thing. Stable medication at baseline, it's hard to do a blood pressure study. There was no drug that would have ever been randomized the way this trial was designed. And select the right patient population. Resistant hypertension is difficult. Along the operator thing, I think it's important to note that when they did analysis of the quadrants of these, so 76% of all the renal arteries did not get a 4-quadrant burn. Did not get a 4-quadrant burn. 6% of the arteries of patients had bilateral 4-quadrant burns. And interesting, they did, the subset analysis doesn't mean anything, they did have a statistical drop in their blood pressure when they had 4-quadrant drop in both renal arteries. So now what? Do we stop? Do we go forward? Where do we go? Well, we still have sympathetic imbalance. And all these diseases you deal with, arrhythmia, anxiety, depression, hypertension, decreased immune, Takotsubo, sticky platelets, migraines, ulcer, irritable bowels, all related to the increased drive of the sympathetic tone. So it's still there, and the question is this going to be a way of treating it? Mike touched on a lot of the hypertension stuff, so I won't go over it. You all know the burden of hypertension, that it's 8 times the risk for having high blood pressure. Craig alluded to the afferent and efferent nerve systems. And realistically, it's been a long journey for high blood pressure. And I think it's still going to continue, and I do think that RDN will eventually prove to work. It's important, though, that we know, as Mike alluded to, where are the nerves? If we're burning in the wrong place, it really doesn't matter. You know, if I burn your finger and I'm supposed to burn your kidney, it's really not going to make a big difference in the renal arteries. And 70% of nerves are located within 4 millimeters of the lumen, so it's important that we have deep penetration of the arteries. There's lots of different technologies, as Mike alluded to. A lot of these projects all shut down when everything went on. Both Boston and Medtronic decided to go forward. If we look at what we want out of an RF ablation, if we were trying to design it assuming it works, we want uniform application, so we know we got adequate depth. We want temperature control to not hurt the artery. And we want to make sure that the blood flow is normal after we're done with the procedure. If you start, we can be critical of what we did wrong, but if you look at the global registries, there is still, particularly in the people who are significant hypertension, 160 and above, there is still statistical significance to the fact in a global registry, no bias into it, that the blood pressure didn't work. Obviously, there have been lots of articles. The black box procedure, both Deepak and Felix have talked about why do we have to have a sham. Very few blood pressure trials got set up to the sham that this did, but the lack of reliable surrogates for reduced sympathetic outflow and the variability of blood pressure measurements, which we know flaw every study, require us to be more rigorous. So to touch on the other things that are there, or at least that we need to talk about, we talk about role of the SNS in diabetes and insulin resistance. Sympathetic hyperactivization causes a change in vascular resistance and induces insulin resistance. In preclinical models, the SNS has been shown to improve glucose metabolism by decreasing, you can see there's a fall in C-peptide following denervation and a fall in fasting glucose following denervation. If we look at obstructive sleep apnea, there's a group that generates AFib as well as hypertension. Sympathetic nervous system, a major contributor. There's a causal relationship between obstructive sleep apnea and hypertension. And there's a dose relationship that's been reported between sleep apnea, breathing, and daytime blood pressures, which we see in our clinical practice every day. Resistant hypertension is frequently common, and I think a lot of us order a sleep apnea, and those people who are really having a hard time getting their blood pressure under control. So the apnea index improved after RDN in a small trial back in 2011. AFib, we know some of AFib is sympathetic mediated. If you look at randomized comparison of pulmonary vein isolation with renal denervation without, what was found is that there was, with renal denervation, there was a decreased incidence of AFib with successful RDN. RDN for heart failure, maybe some of the most exciting stuff. If we look at a normal subject, sympathetic activation versus functional class 2, functional class 3, functional class 4, what do we see? That there is higher sympathetic tone in each one of these groups. If we look at RDN for heart failure, once again, all small single-center studies. If we look at norepinephrine levels, that are correlates with mortality. So the higher your norepinephrine, the more likely you are to die from your heart failure. So what's the potential denervation in heart failure? Well, modulation of central chemoreceptors, better fluid balance, decreased peripheral vascular resistance, just like the medications they use to treat them, increased exercise capacity, improvement in biochemistry, and potentially, and there was one study in Czechoslovakia by Oludnek that showed decreased hospital readmissions statistically significant over a 2-year period of time. So what are the next steps? Back to basics. We have to define a patient population. What are we trying to answer? And I would argue that resistant hypertension, as Mike alluded to, is a terrible group to begin that analysis with. A sham trial is required. There has to be some randomization to take away both the placebo and Hawthorne effect. First question we have to answer ourselves, does this work? Despite our enthusiasm, despite me believing the Bears were going to win, does this really work? Trials, which I'll touch on shortly, and then we need to build from there. So as the VESIX trial alluded to, 100 patients Mike talked about, this 2-to-1 randomization, moderate hypertension, not resistant hypertension, washout of all meds, introduce meds after 90 days, Global Marty and Michael Weber, and then look at efficacy over a period of time. There'll only be 10 centers enrolling. VESIX trial looks to answer a single question. Does RDN work for treatment of hypertension? Pretty simple, basic question. Absence of medication should eliminate the Hawthorne and placebo effect, and VESIX device may eliminate device variability that we saw in Simplicity 3. I can tell you, using Simplicity 3, it's hard when you're turning a catheter to really know where are you in 3 dimensions in terms of making your quadrant burns. Spiral HTN, it's a new catheter, allows better contact points. There's 2 arms, one with meds, the med on arm and the no med arm. Once again, looking at a moderate hypertensive group, blood pressure is 150 to 180, ambulatory blood pressure is at 10 points. In conclusion, RDN we do know is safe. Whether it works or not is what we have to discover. Simplicity 3 had multiple positive causes to fail to meet endpoint, catheter, operator, and patient population. Sort of a bad combination for a device. We must first prove if RDN works in hypertension. 2 new trials, and I applaud the fact that they stuck with it. The behind-the-scenes arguments within the companies of whether to just abandon this technology were large, but both have decided to go forward. And I do think other areas of increased sympathetic tone remain interesting, particularly to me, heart failure and arrhythmias, and probably do warrant further research. Thank you so much.
Mark, thank you. Great talk. With that talk, let's ask the next panel to come up so that we can get started on the carotid session. I want to thank all the speakers in this session.
We have the sound turned off. Oh, sound turned. The sound on the mics on the right here, they're not working. It's not working on there, right? Not working now? Okay. Okay, I think we get started on this next session. We have a change in the speaker presentations. We're going to have Carlos Mena present his paper on proximal protection. Is that the answer for carotid artery stenting? Carlos.
Good afternoon. Thank you very much, Dr. Golzer, and to the CVC Symposium for the opportunity to present. Under standard proximal protection, I think that as we embark in CREST-2, there are still some issues that are relevant to the revascularization of the carotid, whether it's a stent or in the arterectomy. And the stenting issue continues to be an ongoing debate. Clearly, stroke is a major problem. As we know, the statistics are striking. There is a significant number of them each year, many of them related to carotid artery disease. And it's important for us to try to perfect the technique of carotid artery stenting. As I see it, distal embolization is perhaps the most significant issue related with carotid stenting, whether it is during the diagnostic part of the procedure or during the actual intervention. And it is the way how we protect the brain and or the type of stent, two of the areas that are actively being looked at. Embolic protection device during the carotid artery stenting can be done in two ways, basically. The distal protection, which traditionally has been a filter embolic protection device, or a distal balloon occlusion, and or proximal protection device, which is basically, today in the United States, is the MoMA device. And these are two cartoons basically showing how the device works, but I'll show that in a second. The characteristics of ideal embolic protection device should be that is an easy device to use, stable device position during the implantation, maintain cerebral perfusion, complete protection for all parts of the actual stenting procedure, including crossing the lesion. Use a preferred guide wire, gives you that flexibility, minimal no restrictions on landing zone, applicable to all plaque morphologies, captures debris of all sizes, effective aspiration, and documented results in high-risk lesions and or patients. The distal embolic protection device have some pitfalls, although it's the most used device. It's relatively easy to use, and geographic visualization is often easy. Keeps cerebral perfusion during the procedure, and generally well tolerated and does not require collateral flow to treat the same hemisphere. Overall, the results are favorable, but there are some situations in which it's not quite the case. And the reason why that is no cerebral protection while crossing the lesion, that becoming one of the biggest issues, requires a straight landing areas of the artery to be able to be deployed, difficult to deliver and use in tortuous internal carotid arteries, and filter may not provide complete cerebral protection due to malapposition and or the size of the hole of the filter. Filter may allow passage of particles less than 150 micron. The filter may become filled quickly with debris and require aspiration, may cause spasm and dissection, and difficult to retrieve when you place the stent in certain situations. So these are some of the issues that I highlighted. No cerebral protection as you are crossing the lesion. So imagine a tight symptomatic carotid where there may or not be a thrombus, and you decided to do a stent. Crossing that lesion and delivering a filter may be the moment where you're going to have your embolic event, and then the whole procedure goes south. In addition to that, there's some instances in which the filter itself cannot have a complete apposition around the vessel and is around the device itself where the debris is going to migrate and you're going to have your adverse event. The particularly that the filter actually can hold may also become an issue. And again, we see often patients that have a carotid stent, you do MRIs after, and even though they are silent clinically, they have multiple hits on the brain. Significance of it may at this point be undetermined, but you want to believe that there is a negative effect of those. Filters get full quickly, and from the coronary we have these events of non-reflow and then the difficulty to manage that debris as you are doing such. And then when the filter is full and you're trying to retrieve it at the end of the procedure, you may have, again, an adverse event. So all these issues become a clear problem of distal embolic protection devices. Having said that, again, in the United States and Europe, most of the carotid stenting procedures are done with this type of devices. So the proximal protection device concept came around, and to many of us, it makes sense. It suspends the blood flow through the ipsilateral carotid, obviously, as you place it. And the basic principle is that you're going to inflate a balloon in the sternal carotid and the common carotid, and by virtue of that, you're going to suspend the flow in that area, and you're hoping that through the collaterals, the circle of Willis, and others, there's going to be perfusion of that side of the brain. So the protection is established before crossing the internal carotid lesion, so you're not manipulating the plaque at all. There's no issues of distal landing zone. Guy wire, you can use any guy wire that you may want to use, depending on the lesion, calcification, et cetera, et cetera. Backup support, device stability during the two occlusion balloons is fairly easy. In other words, you have those two balloons that act like anchors that will allow you to deploy pretty much anything that you need to. Effectively capture debris of various sizes or virtue of aspiration at the end of the procedure. And the cerebral protection by debris, as you do this aspiration, enhances the effect, the protective effect of the device. A few years ago, months ago, Gore had their device. Since then, they made a decision to take them out of the market for cost, basically. And then, as I said in this slide, the MoMA is the only one available, at least in the US. There are two sizes, 8 and 9 French. In the US, the 9 French is the predominant. And this is a cartoon showing what I had mentioned before, in which you inflate the sternal carotid balloon, the common carotid balloon, and through all those multiple collaterals shown by the red arrows, you will perfuse that area as you do the intervention. Intolerance is an issue, but I feel that intolerance is somewhat subjective, and what that I mean is different to have someone who has warfinding difficulty for a few seconds versus someone who goes hemiplegic while you're doing it. So the definition of it, I'll get into it in a second, but it's important to understand that. Here is an angiographic example of what I just showed you in the cartoon, and you can see the sternal balloon inflated and the common balloon inflated, and you see a column of contrast, static, while you do your intervention, and nothing really is moving forward, ideally. So these are the benefits that I just mentioned, so I'm not going to expand on it. You can see a complex carotid lesion, as you see. This is not to discuss whether it should or not be doing in a stent way, but if you were to do it, here are the issues where the MoMA becomes fairly a good way to protect. You got to make sure that all those collaterals, specifically the thyrocervical branch, is occluded in the sternal carotid, because otherwise you're not going to have complete flow reversal and you're still going to have events. But this type lesion, using any guy wire that you may use, the tortuosity, all those problems are overcome by using the proximal protection device. Should you use a distal, it will be more challenging, and probably you wouldn't even attempt it. There are certain things that need to be in place to be able to use it. You need an external carotid intact. With the Gore device, it wasn't an issue because the two systems were independent. With the MoMA one, there is a way to get away with it by cutting the sternal balloon. It's off-label, you shouldn't do it, and there's a way to do it, but you got to be really careful, because otherwise you have pretty much a sharp object in contact, direct contact with the lesion that you're trying to treat. So there is a way, but you need to learn that. There's got to be some collateral support of the to the treated hemisphere, and this is what the tolerance issue is about. The main thing is that you need to be able to do your intervention rather quickly once you establish the flow reversal. You cannot leave it without perfusion for 5 minutes, 10 minutes, because that's when you're going to run into trouble. 20 seconds, 30 seconds of flow reversal should be enough to be able to do this procedure. And then again, given the size of the device, you need to be able to fit a 9 French system into the patient's artery and through the common iliacs and common femoral. This is what the device would look like. I'm showing the Medtronic one for the reasons I mentioned before. It has multiple parts. It looks daunting the first time you open the boxes, but once you've done a couple, it's pretty simple and straightforward. And this is basically the way it would work. You have those two balloons. You're able to perform your intervention, and at the end, you aspirate and you get debris like I'm showing you in that slide. And this is the way you get it up. You engage first the sternal carotid. You deploy the system there. You make sure that you occlude the thoracocervical branch, and there is a fixed distance between the sternal and the common carotid balloon. Then you inflate sequentially the sternal, then the common. Flow reversal is established, and you want to make sure that all the branches are occluded. And by virtue of doing that, you're ready to do your intervention. Make sure that everything else that you're going to need for the actual intervention is ready, so you're not delayed as you're doing the intervention. And here I'm showing basically what you want to try to do. You inflate the sternal, you inflate the common. After that, you cross the lesion, you angioplasty, you stent, you aspirate, and hopefully you should be done. One thing that is important is that you want to make sure that that flow reversal is completely established, and you want to do it either by angiography and or hemodynamics. I prefer doing it by hemodynamics, and it's just like wedging a Swan-Ganz catheter, and you can see the pressure tracing dropping in the common carotid as you inflate the balloons. Another important issue with this pressure tracing monitoring is that there have been a few studies highlighting that how low the pressure drops, 20 to 40 millimeter being the cutoff, can predict whether the patient can or not tolerate the device as you're doing the intervention. So it has some relevance. At the end of it, you deliver your stent, and then in the same sequence of events, you deflate the balloons, and you are able to retrieve that. Make sure that you aspirate, obviously, before you take the balloons down, because otherwise you have all this stagnant material there, and it is going to embolize, and that's exactly what you're trying to prevent. And I'm showing that here, the sternal balloon goes down, the common carotid balloon goes down, and you are able to withdraw that. One thing that I want to show you is that the sternal balloon has to be fully deflated because you have the stent often trapped in the sternal balloon because you put the stent across the sternal carotid. So it's important to understand that. As you develop your experience, when you shouldn't use it is when the sternal carotid is occluded, as I said before, when the carotid lesion is at or before the bifurcation, the contralateral occlusion, especially if you feel that the collaterals are not adequate to guarantee perfusion to the brain in that situation, when there is severe adverse aortic arch, and then obviously when the operator is not qualified to do that. There's some clinical data to show that. This is the clinical trial that allowed the approval of this device. I just want to show you, for the sake of time, the results. Intention to treat, there was a rolling phase given the complexity of putting the device in place. The typical outcomes for a carotid stent trial, even though this is a protection device. And then what I want to show you is the results as way of the endpoint, which is a 30-day stroke and MACE. And you can see that both symptomatic and asymptomatic, octogenarians or not octogenarians, there was a significant improvement compared to distal embolic protection devices. And I just want to, in terms of this, which is very important, is this adverse events. Many people are concerned about the size of the device and how complicated it is to get it up into the common carotid and the internal carotid and being able to safely do the procedure. They didn't have any significant effects. So in summary, this being the last slide, proximal protection devices, I think, that are an improvement in the way we protect the brain during carotid stenting. I certainly have changed the way I practice in terms of using this device for all the symptomatic patients, especially unless there is a compelling reason why not to. For the asymptomatic patients, if there are any high-risk features for distal embolization, I also prefer these devices. Thank you very much.
Thank you, Dr. Mena. It was a great discussion. So now we're going to go to the top of the agenda and get a perspective from my colleague Vinay Kumar, who's going to give us an explanation of, if end arterectomy is so good, why should we even think about carotid stenting?
Yeah, interesting, Mike, because when Jafar asked me to do a talk from surgeon's perspective, and there's a lot of things which most of us don't know. And ever since the introduction of carotid angioplasty and stent placement, we have comparisons and debates nearly every meeting I have attended in the past 15 years. But are we comparing apples to apples or apples to oranges? Well, let's just look at those people who have forgotten to read the surgical text of carotid endarterectomy. It's indeed a great procedure which was invented by Michael DeBakey in 1953. And Lancet was the first journal which published the article from England. Dr. John Connolly wrote, "This is an epic operation which changed the course of history as far as carotid disease is concerned." Lancet's first publication was 1954 by Escott and their group, where they did the first reconstruction of the carotid artery. And since that time, multiple procedures have been modified and with patch or without patch. Now, carotid endarterectomy is a very, very simple procedure which can be done under general, local, or cervical anesthesia, because this portion is very important as we look at into the direction of carotid angioplasty. We do remove the offending plaque. We also close the vessel with or without patch, and usual hospital stays 1 to 2 days. And to circumvent the problem of occlusion, we can also use a shunt during this procedure to protect the brain. It has stood test of time. 3 major trials. Just look at New England Journal of Medicine, 1991. More than 2,500 patients randomized for carotid endarterectomy in symptomatic trial, and final result was 70 to 99% carotid stenosis does respond fantastic to carotid endarterectomy. European colleagues were not far behind, 3,000 patients in CS trial, and showed the same thing, that 70 to 99% stenosis of carotid artery is benefited by endarterectomy. Well, the trial didn't stop there. In 2002, Henry Barnett and their group in Ontario, Canada, looked at all the trials and actually came to these final conclusions. Risk of stroke and benefit from the procedure are greatest for symptomatic patients for at least 70% stenosis. Patients with 50 to 69% stenosis usually don't have much benefit, and risk of postoperative stroke and death rate is higher in patients with contralateral occlusion. So then it becomes a standard of care. For years and years, we have done carotid endarterectomy in nearly every patient who is symptomatic. Then comes a new kid on the block, a carotid angioplasty and stent placement in 1994 and 95. And over 18 years, this procedure has been perfected by changing the sheets, wires, specific stent, and embolic protection devices, which you just heard from Dr. Minia. Well, what happened? We did tons of carotid trials, Cavatas to CREST trial, and every trial it showed the stroke rate was higher compared to carotid endarterectomy. All the trials have failed to show comparable result. And my co-moderator here, Dr. Woley, once told me, carotid trials have hurt us. Why does surgeons don't like it? Problem is, 2003 and 2004, this is a paper from Mass General. They looked at all the Medicare data and identified 259,000 patients. And by their analysis, CAS was independently predictive of postoperative stroke. Very impressive paper. When you present in a surgery meeting, nobody's going to listen to carotid angioplasty. John Lynch and their group in Omaha, Nebraska, looked at all the data from Medicare and also said the stroke rate at 30 days is 1.6% higher in carotid angioplasty than carotid endarterectomy. And they concluded that knowing that, these patients can be treated easily by endarterectomy. Look at impact of center of Medicare, especially when we're talking about SVS registry. The completion data from there was CMS high-risk criteria doesn't hold water at all, because these high-risk criteria, patient can easily be treated by carotid endarterectomy utilizing local anesthesia. So what are the issues for vascular surgeon? When we look at this data and robust data of carotid endarterectomy for past 20 to 30 years, what are the problems? We have a tremendous push by the industry. Abilities of other specialties to perform carotid angioplasty, like cardiologists and radiologists. And then they offer DRE courses like drive-by learning, expert operators' ability to make the procedures look very simple during these meetings. And then we have to learn new technology like wires, embolic protection devices, stents, etc. So why accept a procedure with inferior results? We look at this way. If I have a Porsche, do I want a Ferrari or do I want to go a bit of jalopy? Obviously, most surgeons are going to go for a Ferrari. But saying all that, carotid angioplasty is here to stay. It is for patients like this. Look at the patient on the left side. He has got no neck. He has got broken neck with a fusion. and now we cannot hyperextend the neck to expose the carotid artery. The other lady has a tracheostomy with tracheomalacia, not an ideal candidate for placing incision in that neck area. Or lesions like this, long lesion, you have to go all the way here to cut the clavicle to reach that lesion. On the second picture, you can see high-grade stenosis of common carotid artery, and a third picture is base of skull lesion. So what are the high-risk criteria? The high-risk criteria in my book are previous carotid endarterectomy with symptomatic stenosis, high lesions or low lesions, radiation therapy to the neck, tracheostomy, short neck with C-spine fusion, myocardial infarction in past 4 weeks, and severe pulmonary disease, which can really cause even the problem under local anesthesia. Relative indications of severe tandem lesion. This has not been proven. Age greater than 80, open heart surgery needed within 6 weeks, contralateral carotid occlusion or laryngeal palsy. And to add to them, unstable angina and congestive heart failure by New York Heart Association class 3 and 4. Additional criteria is multiple lesions in common carotid artery, intrathoracic stenosis, and salvage after failed carotid endarterectomy. And this is a picture from one of my cases where I have placed the patch and still was not very happy, shot a picture and did not have a flow, was able to place a wire through that area, and then balloon angioplasty and stent placement to achieve great result. So is it carotid angioplasty is here to stay? Well, those people who say it's a less invasive procedure, perhaps not. Less expensive, definitely not. It's a good procedure, I think it is. Why? Because the latest data from CREST, and this is a paper written in Journal of Vascular Surgery by surgeons, Dr. Carlos Timuron from Dallas, he finally said when performed by surgeon, carotid angioplasty and endarterectomy has similar net outcome, although the peri-procedural risk may vary, lower stroke rate with CEA and lower MI with CAS, indicating the step in the right direction now. My personal experience since 1994 to 2012, I have performed 1,013 endarterectomy with 3 major strokes and carotid angioplasty 801 with 2 strokes. And most important part was the last 103 cases of FR2, we had 0 stroke rate, indicating there's a learning curve to this, and more you do it, better you will get. So keys to the success for surgeons or anybody else who's going to do carotid angioplasty is right patient selection. Avoid operating based on carotid duplexing alone. CTA and MRA are required for better delineation of anatomy and intracranial vessel description. And like Dr. Woolley always says, avoid hostile arch. Calcific, atherosclerotic type 3 arches are no-no. Learn device and develop a comfort level, and when in doubt, please get an opinion. I can summarize by quoting this Chinese paper. America is covered with Chinese devices, so why not Chinese paper? They concluded that carotid angioplasty and endarterectomy, with regard to incidence of stroke and death, this procedure may be considered complementary rather than competing modes of therapy. So remember, there are 2 modalities to treat carotid artery occlusive disease, carotid endarterectomy and carotid angioplasty. And in right hands, both are equally effective when chosen for selected patients. And now we do have a choice, and we can use them. Thank you.
What a uniquely thoughtful perspective. I wish others who control the money would hear that talk. That was great. My co-moderator, Mark Woolley, is going to take us down some of this discussion regarding the issues of CMS coverage affecting patient access and new technology. Mark?
Thank you, Mike. So let me then present here. The problem was, let me summarize for you where I think we're going here. So when we hear Vinay's talk, and I totally agree with everything he says, that endarterectomy's had 64 years of experience. Carotid stenting's had 15. So carotid stenting is a technology situation in evolution. We're not there yet. We're definitely not there. So that's why I'm so opposed to entering these trials with existing technology. We're still in evolution. However, to complex this whole situation, we have few procedures in the history of medicine have had the scrutiny and closely scrutinized situation that has undergone carotid stenting. Nothing matches it. So the question is carotid research dead? I think no further research or industry support has definitely damaged carotid stenting. I think 20 years without reimbursement is a significant factor. I think CMS's refusal to reimburse in spite of FDA approval of Sapphire Crest still refusing to broaden the coverage decision. I think carotid stenting at one time was a standing room only situation, and that's totally disappeared from the screen. I think there are very few sites in the world really looking seriously at carotid stenting other than Italy, where 90% of all carotid procedures are done with stenting. So why do these problems occur? I think one, turf war backlash has definitely affected us. And I think secondly, our failure to develop a cohesive group, and even CMS has agreed, you have not come to us with a unified opinion. That's been very harmful. I also think that the poor results we had in the early stages of stenting are unforgivable. And I think we tried to imitate the coronary data, never did the coronary data because we're obviously dealing with the brain. The second is the continued requirement by CMS for more peer review, especially RCTs, not registries. They're not interested in registries. I think CMS's refusal to agree, even when there's been FDA approval, has been very harmful. And I think, quite frankly and honestly, I think vascular surgeons have had a major, major influence on CMS. Don't know the answer. But when you look at the distribution of where we are, you can see on the column on the left, SACI, SIR, ACC, AHA, all of these societies are for stenting, all. When you look at the neurology situation, the Academy of American Neurology, they are not totally for stenting, but borderline. And it's also true for neurosurgical interventions. But when you look at the column on the right, SVS is totally against carotid stenting. Although they say they're doing them, I mean, when it came down to the vote, they were not for CAS. So when we say, well, where did these mistakes occur? They'd occurred early on when we were doing cases like this that should never, ever have been done, including the complex arch. No reason to do procedures with that type of anatomy. Now, this is a patient we saw here recently. 64-year-old male, left hemispheric stroke, prior endarterectomy. So this patient was refused by surgery and sent for stenting. So the question is, could we stent this case? Would we stent this case? He said, well, this is a disastrous looking situation, and surgeons say there are no high risk. So I said, well, if there's no high risk, maybe they should do this case again, because we refuse to do this case. Even though it's critically necessary to be done, we're still following it medically. Now, and again, show you the complexity of these patients if they're not analyzed critically from the angiographic standpoint. You can see here, this patient has both pericallosals filling, meaning the critical lesion, contralateral flow. And then furthermore, you can see the posterior communicating down low, feeding not only the posterior cerebrals, which is acceptable, but feeding both superior cerebellars. So this is a dangerous case, even to be done surgically, and certainly from the standpoint of endovascular stenting, definitely contraindicated. So I think that type of anatomy we need. Now, can we do this case? This is a simple case, but it's a complex curve there. It's not necessary. We can do it, but why take the risk of putting an 8 French or 6 French sheath around that complex common carotid curve with all the shearing and all the wall surface? It's just too possible for embolic events. So how would we do this case? We've lately become interested in transcarotid. I spent some time with Patrice Bergeron in Marseille, where he's doing almost all of his cases transcarotid. It's quick, it's simple, it's done with a 6 French sheath, and it's closed subsequently with a boomerang. And you can see that in very middle, 2,000 units of heparin, low-dose heparin, and closed with a boomerang. So this is acceptable, a very quick procedure, can be done with either proximal or distal flow control. So CMS continues asking for more peer review. In the meantime, we've had experience with 55,000 patients in registries or trials. We have 41 US registries we've done. We have 10 randomized trials. We have 20 years of experience with CAS and 50 years with CEA. So 20 years without reimbursement, so that there's a little wonder that there's total loss of interest in the whole carotid market. Furthermore, I see numbers. We've spent $300 million in carotid trials. And now we're going to spend another $150 million for CREST 2. It's because more data, because now we want to understand, has statins made a difference in the asymptomatic patient with endarterectomy or with stenting? Would they be best managed medically with the statins? So that's what we're going to spend another $150 million to get that. Now, this has already been alluded to. There are certain cases, there are certain situations that are undeniable indications for stenting, and there have been mentioned. Rene mentioned them: previous endocardial stenosis, prior radiation, radical neck dissection, tracheotomy, contralateral vocal cord procedures. So this entire list are indications for stenting, but they are not approved if they're asymptomatic. So these patients have no other option. So what we do is we appeal these, and in most situations, we do one-on-one with a physician, we'll get them approved, but it's very time-consuming and should be an unnecessary procedure. These patients should be stented and reimbursed and not subject to $25,000. If they aren't reimbursed, they have to come out of their own pocket. So what research projects are presently at risk now that we're talking about carotid stenting? I think the significance of microemboli is totally underestimated. Total. I think that's a major issue now with carotid stenting. I think the hybrid stent designs are on kind of a hold, some development. I think we're looking at new surfaces for the stent. We're looking at nanopore surfaces. Nanopore surfaces have controlled elution, so they're ideal for this. And I think the transcarotid access I mentioned, I like the process of that. I think the covered carotid stent may be necessary to control microemboli. And I think more efficient filters presently are a major issue. Now, 4 or 5 years ago, we were interested in redesigning the stent, and this was a research project we undertook, creating a hybrid stent. And we put a micromesh on top, and then the micromesh would control the small 500 micro embolic events. So is this enough? No. This is 500 microns is visible. So all this mesh does, the hybrid stent, stabilizes the plaque. It doesn't control embolic events. And here's Gore's 500 micron. Lovely hybrid stent, but again, not going to control microemboli from the start. Stabilize, yes. Now, what we did in this particular precise stent, we've covered this stent with a nanopore surface. So this stent has a nanopore surface on it for controlled elution. And the nanopore surface is only 2 micrograms per millimeter square. So it's ideal in terms of surface application. So we think this type of activity, for example, polymer-based drug delivery is complex chemistry. On the other hand, nanopore surfaces are not. Nanopore surfaces, just dip it in whatever you're interested in, heparin, any of the anticoagulant agents, and you have a nanopore surface. So we like that approach for ultimate self-expanding stents. I think ultimately to control the microemboli, it may be necessary to cover the carotid, whether it's fenestrated in the external or just cover the internal and cross over the external. One of these reasons may be the only way looking at the potential of totally controlling embolic events. And also I think there's research to be done on rapid endothelialization of the surfaces in the newly designed stent, all possible. But in the meantime, it's been on standstill because there's no funding. Isn't it interesting that Bullfrog, Mercator's doing? It's a microneedle. It's a 60 microgram needle, perforates through the intima into the adventitia and delivers dexamethasone for restenosis. So these are interesting areas that simply are underfunded and going nowhere. So then I asked myself, is CREST-2 worth $150 million? To prove what? To prove that best medical management is better than carotid stenting? That may be true. Will it be better than surgery? No. It won't be better than CEA. So it reminds me also, this comment was made earlier, when Michael DeBakey was interviewed whether or not he would enroll in NASCET, symptomatic patients versus medical management, he said, why would I enroll when I already know the answer? We feel the same way about CREST-2. We already know the answer if we go presently with existing technology. So I think the take-home message is this. For unclear reasons, CMS has destroyed research in carotid stenting. And it'll be 7 years before we have CREST-2, and they'll answer that question. So industry has already withdrawn from funding for carotid research. So there's basically no significant research occurring. I've demonstrated research areas that need funded. And I think CAS presently is not prepared to enter CREST without the solution to microemboli. And if the microemboli are significant enough, and I'll talk about that in a later lecture I have, if microemboli are significant enough, they could stop the trial. So microemboli occurring in as high as 70% of all the patients that we stent, 70% of the patients have microemboli in the data to present. And I think the CAS has nothing to gain and much to lose in CREST 2. Thank you.
Thanks, Mark. Hard to disagree with anything you said. I guess the only thing I would say is I think carotid endarterectomy is at a bit of risk in CREST 2 as well. So that, yeah, I do. I do. In fact, I find it surprising that the surgeons are willing to enroll in CREST 2, but that's for a different discussion. So I am asked to speak about where the future lies with carotid stenting. If we could pull my slides up. Perfect. And a lot of this stuff you've heard already, so we'll be able to fly through that, and some you'll hear after my talk. For this specific discussion, I have a number of relevant conflicts. Abbott, Boston Scientific, Cordis, Covidien, and Medtronic, they're all in this in one degree or another. I don't get paid for the advice I give them, but I do give them advice about this. So I'll start off, for those of you who don't know me, I'm not a vascular surgeon. I am not an interventionist. I'm not a neurologist. So what the heck am I doing here? Well, what I'm here is really to show you my cards. I'm going to show you the facts and let you make your own decision. You guys are all too young, but this is Jack Webb from an old TV show. He used to say, "Just show me the facts, ma'am." Remember that, Mark? Oh, you're too young, too. I remember. This was also Jack Webb. You know, he made his money advertising for Chesterfield cigarettes. So we've already heard about stroke and the magnitude, but it's a very expensive disease as well. The management of patients following a stroke is devastating to the economy of the U.S. healthcare system. Dr. Abbott had set kind of the field on its edge when she published this seminal paper reviewing the medical treatment arms of carotid intervention trials. You'll notice this went back from 1975 all the way out to 2005, and she suggested that the annual stroke rate for patients treated medically dropped from about 4% to less than 0.5%. Now, I could spend the next half hour pointing out the serious methodologic flaws in this, but the oval purple chart there highlights two studies in which none of the patients in the SMART or OXFAST trials were patients you would have referred for a carotid intervention, not a single one. These were asymptomatic patients with 50% carotid stenosis that were not independently adjudicated. So I think the argument's moot. Bottom line, we do not know the efficacy of medical therapy for high-grade intervention-eligible patients with carotid disease. At least I don't know it. Now, this is perhaps one of the most important recent papers. I don't know why this has been missed, but I'd love to hear the panel's thoughts on this. This was actually published from our place. What we did was we looked retrospectively, so accept that there was that limitation. At 126 carotid arteries, 88 of which were considered severe by our vascular lab, and 38 considered very severe. None of these people got an intervention. They were all treated with medical therapy. So here's the demographics of the group, usual panoply of cardiovascular risk factors and atherosclerotic risk factors. And you'll notice here that a lot of these patients were treated with appropriate medical therapy. I mean, these were really well-designed and managed medically treated patients. The only difference between the group of severe and very severe were those in which we don't really think it matters, like whether they took clopidogrel or not, or whether they were treated with an anticoagulant. Oh, one more thing to point out. Notice here that there was a statistically significant difference in the LDL cholesterol between those with very severe carotid disease and those who had severe carotid disease, suggesting that maybe they could have had a bit more intensive lipid-lowering therapy. But when you look at what happens to these patients, looking specifically at the freedom from an ischemic stroke, you'll notice that in the entire group and in the group with severe or very severe stenosis, it really didn't matter that they were on maximal medical therapy. This, in fact, is looking at the statin use and whether that made a difference. It did not make a difference. And this actually looked at survival and symptom-free survival in these patient populations. Now, these are the patients, theoretically, that are supposed to be enrolled in CREST-2, right? These are the ones. And now I think if I show you this, if you believe this, I think you got to be a little more nervous, Mark, about enrolling in CREST-2. So, admittedly, medical therapy is the backbone of all treatment for carotid disease. That includes blood pressure control, aspirin, a high-intensity statin based on the new guidelines, aggressive tobacco cessation, tight glycemic control if the patient has diabetes. But I would argue to say that we do not have any data that says that medical therapy alone, which is the randomization arm in CREST-2, is protective from events in patients with high-grade carotid stenosis. So carotid stenting, you already heard a lot about this. I'm not going to spend any time. Tons of data, all leading up to this major trial, CREST. You couldn't have drawn this endpoint curve if you wanted to any closer before you started randomizing. This was dead square even. It should have settled any debate, but in fact all it did was foster more controversy, more disagreement. And why? Well, you've already heard some of this. The surgeons feel that carotid revascularization is performed for stroke prevention, and that in CREST, endarterectomy reduced the stroke risk more than stenting. The unfortunate excess myocardial infarction rate, according to some, in patients with endarterectomy is really not relevant. Interventionists feel that carotid stenting did just as well as endarterectomy, that the excess stroke risk with stenting was minor, non-disabling stroke in which the symptoms were gone, or the findings were gone, 6 months after randomization, and that the MI risk of endarterectomy is just as important as the minor non-disabling stroke risk. And the neurologists feel that although the outcomes were low, medical therapy is better than any revascularization. So you can see all this did was add fuel to the fire. I won't spend any more time on this, you know this. So people have tried to come up with models that allow you to predict who's going to have an adverse event after endarterectomy, so that's why you have those anatomic and clinical high-risk features, and who's going to have an adverse event after carotid stenting. And in fact, this was well modeled and demonstrated that you can, in fact, predict who's going to have an adverse event from carotid stenting. And I think all of you who do that know what those risks are. So maybe the argument is it's too expensive to do carotid stenting. I mean, after all, the surgeons tell us that they can do these procedures with less than 24-hour hospital stay. They hardly ever see the inside of an intensive care unit, right? I mean, most of these people just go to a routine floor and off they go. Well, it turns out that this study, looking at the CREST trial cost-effectiveness curves, demonstrated that there was absolutely no difference in cost-effectiveness between carotid endarterectomy and carotid stenting. And in fact, the conclusions say other factors than cost-effectiveness, so things other than price, should be considered when deciding treatment between carotid stenting and carotid endarterectomy. So, what's new? Well, I'm not going to spend any time talking about how to do this. That's what the next presenter is going to talk to you about. But this is the latest to receive FDA approval for the use of carotid stenting. This is the transcarotid artery revascularization. Contrary to what Mark told you, this is a surgically done procedure in which an incision is made in the skin overlying the common carotid artery. And this was approved based on the Roadster study, which is an IDE study, compared to an objective performance goal of 11% for stroke death and myocardial infarction. I won't go through this in any great detail other than to remind you that they did include patients who had anatomic high surgical risk, like restenosis after endarterectomy and hostile neck. They excluded patients, of course, who had common carotid disease at the entry site, so ultrasound was required ahead of time, and that the puncture site, or the distance from the clavicle to the bifurcation, was too short to put the delivery system. You'll notice here that they did include a significant number of patients who were older, 75 or 80 years of age. And the procedure went very well. There was excellent acute technical success with placing this device. The results are as good as any we've seen in a prospective multi-center registry. No major strokes. The stroke death and MI rate was 3.5 and 2.9%, looking at intention to treat versus per protocol or on treatment. They did have a very low cranial nerve injury rate. And if you look at subgroup analysis, these were the high surgical risk patients, no major or minor strokes. So this performed extraordinarily well. It met the primary endpoint. They had carotid endarterectomy-like stroke rates. The procedure time was brief, and there were no permanent cranial nerve deficits, so they got FDA approval. So just in wrapping it up, who can currently receive carotid stenting in the Medicare world? Well, it turns out of this grid, only one component, which is not an equal quarter, by the way. This is a relatively small percentage. Those symptomatic patients with high-grade carotid stenosis are eligible for reimbursement unless they're in the CREST-2 registry. Mark already talked to you about this. I just honestly don't understand this trial. I don't understand why it was designed like this. I don't understand why it was funded. I really don't. Now, what's interesting is that CMS agreed to pay for it. They will reimburse if you do carotid stenting in the CREST-2 trial. They select operators based on experience. You'll notice here that they must have done at least 50 total procedures. If they've done less than 50, they have to have done at least 8 over the last 2 years. So, I don't know, you tell me if that sounds like a lot. You have to be in a registry in order to participate in this. So there's 2 registries you can be in your site, the SVS VQI registry or the NCDR. Both are eligible. And if you are in the randomization part of CREST-2, you can also be in the CREST-2 registry, which means that for every patient you randomize, you can then do a patient as an on-label carotid stent and get reimbursed as long as you follow the CREST-2 registry rules. So right now, and in the near term, only symptomatic high surgical risk patients with high-grade carotid stenosis are eligible for carotid stenting. And as long as you participate in the CREST-2 registry and do one-to-one enrollment, you can also. Now, there are a lot of people who are upset about the limited availability of carotid stenting. I just have to show you this as my wrap-up because it'll make you laugh, I'm sure. This was from a meeting just a couple of weeks ago in Orlando, Florida. This was the brochure. You'll notice here that the keynote speaker that I'm calling your attention to is my good friend Chris White, who's the chief of medicine now at the Ochsner Clinic, who's been known not to be understated about his opinion. And the title of his talk was, Uncle Sam Commits Malpractice, CMS Kills Carotid Stenting. Thanks very much.
Thank you, Mike. Our next presentation, direct carotid artery puncture or complex carotid lesion, Aravinda Nanjandappa. Aravinda?
Thanks, Dr. Thank you, Dr. Woolley, and thank you, Dr. Jeff, for the nice presentation. So the rationale for direct carotid access is carotid artery challenges were elegantly shown by both Vinay and Dr. Woolley. Some of them is mostly from difficult anatomy, although the patient characteristic and lesion characteristics do play a role. Most of it is from elongated aortic arch, torsion of the aorta, and the torsion of the aortic arch itself and the common carotid artery. Calcification, atherosclerosis, and tortuosity of the vessels also plays a role. In terms of difficulty to obtain a safe and common carotid access plays a big important aspect of it. If you can't get an access safely within 10 to 20 minutes, probably if you can't place a shuttle sheath in the common carotid artery, then it's not worth it to prolong because the longer time duration has shown a higher chance of stroke. Even the placement of a filter and removal of a filter also was recently shown by Mehdi Sheshbur elegantly in the Canopy trial subset that the dwelling time period for the filter also can determine the stroke risk. Inability to use a flow reversal system due to limited access. I think earlier Carlos Mena showed that if you have to use a flow reversal system, it's a 9 French device and you got to have patent external carotid. The lesion can't be at the junction of the common carotid and the internal carotid. It has to be only internal carotid artery lesion. So these are all the downsides for using either a distal protection or a combined distal and proximal protection. So here is a case where it's a baseline imaging shows not so much elongated arch, but you can see even with the Siemens catheter, there is a step up of tortuosity that you're going to encounter, and trying to place a shuttle sheath or a 8 French sheath, you're going to cause a dissection and you're going to end up with an iatrogenic dissection. So tortuosity of this such common carotid artery with a selected imaging can show you the difficulties and placement of catheter. I think a similar case Dr. Woolley showed why to use a direct carotid puncture rather than trying to put a 9 French sheath there. Here is one of our case where we had multiple attempts from femoral access to place a 6 French sheath in the right common carotid artery. The main obstacle for this was tortuosity of the innominate artery. And I even called one of my senior partners, Mark Bates, who is well known to the panel here. And Mark eventually said, we got to give up and go on a different route. And very rarely Mark gives up on his cases. And then we decided to go different options. So the reassess the suitability for carotid endarterectomy with high-risk outcomes, that's one of the options, but patient already has an endarterectomy, and this is coming from the surgical group itself. Brachial or radial approach you can try, but I'm not sure how much brachial approach will help in pushing the catheters to get a 9 French sheath up or a 6 French shuttle sheaths. Direct carotid puncture is possible, but risk of retropharyngeal hematoma exists, especially in a patient who has got both radiation and the scar. It's going to be hard for the direct access puncture to work, because if there is fibrosis, your closure devices may not work. So we thought of direct carotid access with a small cut down, but under narrow block, that was the option we chose. Because of the COPD, we couldn't give general anesthesia to this patient. So direct common carotid artery cut down with a sheath, you can see the incision is not much big. This is just a blown up diagram, and you can put something like a bright tip sheath so that you don't work close to the radiation and get radiated. You do need some proximal and distal control using the loops, just like how anybody does a femoral artery endarterectomy. They do a small carotid opening, and then it's needle access, and then you just need the distal control and the proximal control so the patient doesn't bleed when you take the sheath out. So once you have the loops for distal and proximal control, it's still based on just a purse string suture rather than doing a patch or an endarterectomy there. So some of the tips for sheath placement, what we have learned in our center is use of micropuncture to access the artery. We inject the contrast from the micropuncture needle itself to access the external carotid artery bifurcation, so that the micropuncture wire itself can be placed into the external carotid artery, and through that we take the dilator into the external carotid artery, and then we place a stiff wire so that we are not manipulating the internal carotid artery lesion at all. If you're not careful working at close angles, you can easily cross the lesion with a big sheath, and that's a no-no, and that can cause a clear dissection and also can embolize. And here is the case. You can see the internal carotid artery is a tight lesion, and there's even a post-stenotic dilatation. Once the sheath is placed, you can appreciate the sheath is very close to the origin of the internal carotid artery. You have to be careful not to push the sheath anymore, and follow the same steps as a transfemoral carotid artery stenting, crossing the lesion with a bare wire, and then placement of a filter. If you use a long 35 centimeter sheath, you can avoid the radiation field. And then the steps are the same way. You have the filter higher up, and then you have a stent and a balloon, and then you can see pristine results of 90% lesion reduced to almost less than 30% residual lesion. The next steps are easy, and the questions come out with what is the data, and I think Mike Jeff went through this. This is data from the Roadster trial. This is different from what I showed. It's not a distal protection device. It's a proximal protection device with occluding the external carotid, and then you do a shunt from femoral artery to the femoral vein. Interestingly, despite only surgeons doing this trial, the stroke rate and death and MI were comparable or even lesser than the CREST trial. Of course, in CREST was 1-to-1 randomization. Here there were 2 of them, intention to treat initially, and when the protocol came out, that clinical trial results showed better results with 2.9% risk of stroke. Only one thing was not clear with the paper was if neurology had adjudicated these strokes or not. And prior to the discharge, NIH stroke scale was administered, but whether it was administered by non-neurologist or a neurologist is unknown, but the cranial nerve injuries, everything is very much acceptable. So the direct carotid access, what are the advantages and disadvantages? You may benefit the high-risk carotid patient, but low-risk patients also can benefit once you have experienced operators, but there is a steep learning curve. You need new equipment such as short wires, filters, and catheters. Only one company is invested in it. You can use the similar equipment what we have, but you've got to modify some of the things. There's always risk of radiation to the hands, because when you remove the sheath and placement of the sheath and manipulation will need radiation. Also, there is a risk of retropharyngeal hematoma if your closure device doesn't take, and early experience what Arizona Heart Center showed some of the retropharyngeal hematoma can be even contribute to mortality. So in conclusion, direct carotid access is feasible in patients with a difficult arch anatomy and difficult femoral access. We do need good anesthesia team and expertise in nerve block. Patients will be wide awake and you may need to sedate them to have reduced anxiety. You do need a good working relation with the surgeon to assist in cut down and closure. And the surgeon also needs to understand this is not the incision done for carotid endarterectomy. This is just a small incision and you need to have a good team to work with. If you do get such a team, then you can have good results. Thank you.
So Mark Woolley's going to end this session by telling us if bad filters are going to be the end of the carotid stenting.
All right. Okay, so let me begin here. So the question is, will inefficient filters be responsible for issues on carotid stenting in the future? Now, let me tell you a little bit about this. I guess I have to give my summary. No? All right, disclosures. Slow response here. There we go, okay. We became interested in carotid stenting and filters when CREST reported roughly a 2% difference in stroke for endarterectomy versus CAS, and we thought, well, let's investigate that a little closer. Now, we had years ago at CMU did a very, very detailed study with a computational flow model analysis analyzing the efficiency of the existing filters. And it was a thesis subject for Gail Sweetertech. And we analyzed, obviously, Accunet, AngioGuard, FilterWire, SpiderX, and Gore. And we came up with this kind of information. So when we saw this data that Accunet was the sole filter for CREST, and then we said, when we looked at NAV6, we said there's a 50% difference in the efficiency of these two filters, both made by Abbott. So the question came up then, if we had been using NAV6 in CREST, would that 2% stroke difference been corrected? It's possible. So then we decided, which particles are we having a problem with? Now, I showed you 147 micron particles on the last, and they were obviously inefficient Accunet. Now I'm showing you 200 micron particles. Now, 200 micron particles begin to be efficient. Even Accunet's fairly efficient at 200 microns. Not a big difference between NAV6 at 200 microns. So the issue then, and you can see the capture efficiency of Accunet, AngioGuard, FilterWire, interesting efficiency. And Gore, also very efficient Gore, and NAV6, quite efficient. And Spider, unfortunately, Spider has 200 micron pores at the base, so you cannot expect Spider to match the efficiency of the other filters. It's just not going to happen with that pore size. So with that in mind, then we said, well, if we look at this a little more closely, and I'll just go through this very quickly, this is a filter wire animation, you can show, this is the wire going through, this is a catheter going through, and you can see the debris that occurs. Then when you deploy the filter, you can see, obviously, during the angioplasty where most emboli occur, you can see even going around the periphery there because of poor approximation of the filter against the wall, you can see the simulated leak. So, and again, showing you, as we blow up the balloon, most activity occurs there. Let me go to the next slide. All right. So we've already talked about MoMA. There's no question about it. MoMA is more efficient than the filters. Definitely more efficient. How efficient? Well, MoMA, obviously, it's our choice of procedure when the external carotid and the anatomy allows it. It's no question we like that. So let me go to the next one. Now, this is Covidian. This is a Spider filter. You watch the video, and you'll see how efficient. So you can see the filter is up, and you can see this massive amount of particles still going distally with the Spider. Now, when we look at the Spider and compare it to Boston Scientific's, which is EPI filter wire, this is a fairly efficient filter. It's primarily used in coronary circulation, but again, shows better efficiency than certainly the Spider. And Gore is even more efficient than the Boston Scientific filter wire. So when we see a patient like this, is an asymptomatic patient who was denied stenting and refused to have surgery, a relative had surgery, had subsequent cranial nerve damage, all swallowing function abnormality. So we had to appeal this patient, finally got approval to have acceptance. Now, what is interesting about the procedure is that you see that external carotid going down. When you see that in your angiogram, you know this patient has vertebral basal problem. And you can see the reverse flow occurring, and we'll show you that. So this is then obviously a simple case to stent, but you still see that external carotid going retrograde. And the reason being then, when we study the right vertebral, you can see the right vertebral up and the left vertebral down, showing occlusive disease at the subclavian. So not a complex situation, so we took care of the stent and stented the subclavian as well with a very nice result. And now antegrade flow in the vertebral. So we're very satisfied with the result. Then all of a sudden, on the post-procedure, obviously pre-procedure, normal MRI, post-procedure we have 3 microemboli in critical sites, frontal, parietal, and occipital, all critical sites, especially occipital where calcarine fissure is. So on the other hand, this is a symptomatic emboli. This is a major infarct. Again, posterior occiput with obviously in that position, calcarine fissure close to that, and they'll have obviously field cuts, clinically field cuts. This will resolve, they'll compensate, but nonetheless, it's a definite stroke. So what about endarterectomy? Endarterectomy is also not completely safe in terms of microemboli occurring. Here again, critical temporal site from prior endarterectomy. So we said, well, if we analyze these particles, what are we seeing? We're seeing a conglomerate of fibrin, tagged erythrocytes, inflammatory cells, endothelial cells, foam cells, cholesterol clefts, platelets, old thrombus. So a whole source of microemboli. So we're calling these hits. They're not hits, they're emboli. So when we look at that, we say these new DWI lesions, carotid stenting, 37%, endarterectomy, this multi-center, 32-center registry, 10% for CEA. Very impressive. So with the closed cell stent, open cell stent, I'm not convinced of this data, but nonetheless, it does show the closed cell stent less frequent than the open cell. But the question is, if these embolic events are occurring, should we be putting these patients on double antiplatelet therapy? Because they are minor strokes, just not symptomatic. And we say, is filters more efficient than MoMA? Well, we've always shown there's almost twice the difference between filter and proximal flow control in this Hamburg study. The proximal flow versus filter is another study, 62 patients, 87% with a filter, 45% with a proximal flow control. So proximal flow control is not that benign in terms of microemboli. Obviously, I think these future trials must include post-procedural diffusion-weighted imaging. Otherwise, it'll be too confusing. Another signal summer study, 161 patients, CAS 42%, 2 strokes, CEA 11%. So again, CEA is definitely in a lower range than MoMA and definitely in a lower range than filter. You can see this obviously tight lesion in the internal carotid, external carotid, obviously not a MoMA candidate. And you can see a very nice result. And then this was the pre, shows you contralateral filling across the ACOM. And again, a periventricular embolic event, microemboli, asymptomatic patient. So my point is that I don't think we can continue to ignore, and certainly we like the hybrid stents, because I pointed out in an earlier lecture, these hybrid stents still are not going to control microemboli. We're not concerned about the macro. We're already efficiently capturing 200 micron particles and above, but it's the problem that even with an integrated filter, it still doesn't answer the question. You can see in the middle here, the embolic events occurring during the angio blow-ups, the stent balloon, during the balloon procedure. That's when most of the embolic events occur. And then secondly, at the end there, we don't know what's happening to these patients with these microemboli because we're not following them. So I think that the only way that we can control and compete with endarterectomy, at least to control the microemboli, is a covered stent, either fenestrated or isolated internal carotid alone. And so my take-home message in this situation is that the microemboli have to be taken more seriously. I mean, it's true, they're not causing any symptoms, but they can't be good. It just can't be good to have these microemboli in your brain. And say you're asymptomatic. So I think the post-procedure DWIs may be necessary with continued follow-up for cognitive defects or TIA or stroke. And I think as we look at it closely, I think this could be a major issue in CREST. I think the microemboli concept is just beginning. Thank you.
Thanks, Mark. So this ends this session. I've just been told a 10-minute break, so does that sound okay? 3:45, we'll come back for an important topic on the business of healthcare. Thank you.